which is named Aksharam. This is actually a brainchild of our Oxy president, Dr. Vijaya. We all know that knowledge is supreme power, and imparting knowledge through education and training is the motto of both Oxy and Foxy. Dr. Vijaya will give an overview about this Aksharam course, this webinar series, and take it forward. Dr. Vijaya.
Hi, everyone. Good evening and welcome to this Aksharam webinar series. Good evening, my dear postgraduate students, young consultants, senior Oxians, and my EC members. I'm extremely privileged and honored to be the source person to find the correct resource person who just excelled in the field of obstetrics and gynecology. A teacher is completely satisfied only when the student understands the subject well. And taking this forward, I'm happy to begin this course, the PG webinar series, that is Aksharam, which will be, we will be doing it every month, mostly in the third week, and the date and the time will be intimated to you. And I have fixed the time in the evening because I know most of the people, you'll be very, very busy even on Sundays to log in. Maybe after 6, you'll be little more relaxed and you can understand the classes by an excellent teacher, and hoping to give you an enrichment of knowledge through various teachers across the country and also, if possible, globally. We are planning this every month, and I am extremely thankful to Madam Kiran ma'am for immediately accepting to be joining hands with us for Foxy Educational Committee along with the Oxy Educational Committee in this tenure and in this very, very good subject and very, very good attempt. So I welcome you all, and we will wait for when the President Tank joins and Madhuri ma'am joins. We'll just stop in between and then
I have joined, madam. I have joined.
Yes.
Good evening, sir.
Hi, sir. Hi, sir. Good evening.
Welcome,
sir.
Dr. Tank. Welcome.
Hello. Sorry, I got a little delayed. I
No
was
problem,
actually conducting a delivery, so I got a little delayed.
Oh, you are very much
my God.
entitled.
Okay, sir. My most happiest moment is when I didn't expect that Tank sir should join because he's too busy, and you see his CV and you know how busy he is. In spite of that, because it is our maiden attempt to start this Aksharam series, a PG class. So I'm so thankful, sir. Most welcome. And can I have sir's CV, please? Yeah, we'll start this with the Oxy prayer.
Yeah, first we'll start.
Yes.
First we'll start with the
Lighting of the Kuttavada.
This being the first session, and we always want to thank Goddess Saraswati for the knowledge and education. So we play a small shloka for the Saraswatis.
Yeah.
we'll have the Oxy prayer that will be delivered by Dr. A. Geeta Lakshmi. She is an associate professor at Chengalpattu Medical College. Over to you, ma'am.
Thank you, Dr. Karpagam. Good evening to one and all. On behalf of Oxy, as the Secretary of Oxy Chennai, I would like to welcome the President of Oxy, the Secretary of Oxy, as well as Dr. Kiran Madam, and all the senior Oxyans, the consultants, the postgraduates who have assembled here. And as Karpagam said, it's being a post-Rama Navami, and today being the auspicious day of Thursday, Guruvar, we start with the Oxy prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. So we start with the first episode of Aksharam today. Thanks, sir. I would like to know what baby you delivered. Was it a girl or a boy?
Jaydeep sir is not there. Okay.
So if he
I'm
was
hearing.
there, so was it a
No,
girl or a boy?
I'm here. I'm here.
Was it a girl or a boy, sir?
It was a girl, ma'am.
So we can name her as Akshara. Okay. So we move on to the inauguration. Thank you, sir.
Vijaya madam, we can welcome the chief guest and chief guest.
Yeah. Let me have the pleasure of introducing my beloved president, Dr. Jaydeep Tag. You can see the CV, and then he's the current president, Foxy 24-25. He says chair, YGAA committee, AOFOG, project lead Foxy, USAID projects 20 to 24, secretary general Foxy 2018 to 2021, FRCOG honoris by RCOG, past presidents Mumbai Obstetric Gynec Society. He's so instrumental in a lot of projects, 10 country projects, and was a technical lead in the FIGO project. Now also we are going to do a project over the nation, anemia project, and which will start very, very soon. Over to you, sir.
Thank you. Thank you very much, ma'am, for that kind introduction. I don't think there's any question that when Oxy does any kind of activity and would like my involvement, that I would not be able to make it. It is always my pleasure and privilege. The events are always very well thought of, and they are always very academic. So I should be thanking you very much for inviting me, and it is my pleasure and privilege to be a part of this event. Let me congratulate the president, Dr. Vijaya, and the secretary, Dr. Geeta Lakshmi. I was there just few days back in Chennai, and I saw the vibrant society, and I always love coming to Chennai, not the least because I love watching Tamil movies, particularly movies with
Vijay
Rajnikant
movies.
and Maniratnam sir. Let me also congratulate Dr. Kiran Pandey, madam, who's the chairperson of the Medical Education Committee. She has done some exemplary work, starting with the CG Saraya CME, which we had at the Hyderabad conference. Let me also acknowledge Dr. Sairam and Dr. Malaraj, who are helping to coordinate this event. And finally, let me acknowledge and congratulate you for getting the master himself, Dr. Suresh, for your very first webinar. It is always such a pleasure and privilege to listen to Sir. His not only exemplary in the way he performs the art and the craft of sonography, but also in the way he teaches. There is as much to learn from the way he teaches as there is to learn from the material that he's speaking on. So thank you very much again for having me. It's my pleasure and privilege, and I'm very sure that everyone who attends will definitely benefit from this webinar. Thank you.
Thank you so much, sir. Can I introduce Dr. Kiran?
Dr. Madhuri ma'am.
Madhuri ma'am is not joined.
I think
She will be joining.
I saw her, ma'am.
Madhuri ma'am?
Madhuri?
Join, ma'am.
Hi, good evening. Good evening.
Yeah. Good
Hi,
evening.
ma'am.
Good evening,
Hi.
Dr.
Good evening,
Madhuri.
madam.
It's
Good
a
evening, Dr.
pleasure.
Pandey. I was at the other webinar, so I said I will join.
Ma'am, welcome, ma'am. Welcome to Oxy Aksharam series. Let me have the pleasure of introducing Madhuri, ma'am. She's a Secretary General Foxy. She's the Editor-in-Chief of Jogi, and she was a Joint Secretary and Committee Member of FIGO Preterm Birth. And she has got lots of awards from MOGS and Dr. D.C. Datta Prize. And she is now more than 50 publications in the national and international journals. And she's the Associate Editor of Foxy award-winning book, Gynecological Cancer, 2007. More than that, she's a very, very good friend of ours and very approachable. And welcome you, ma'am. And really so happy to both of you are here. We are really honored, ma'am. Over to ma'am.
Yeah, thank you, Dr. Vijaya. Thank you. First, let me apologize that I joined late because I was with the other webinar and I gave Dr. Vijaya the message I'm joining immediately. So thank you, Vijaya, for your kind and warm words. So respect our most dynamic president, silent worker, Dr. Jaideep Chan, that our Dr. Kiran Pandey, she's a president committee, chair, medical education committee. And then Dr. Vijaya, you can see, I met her recently in Chennai when I came for the oration, and she came down for, to the Madras Medical College, both of you. Then, of course, Dr. Kapurkamanali Sairam. Sorry, I have pronounced you wrong, but, I'm very, very, happy to see all of you. And of course, our Dr. Suresh S., right? He is not a radiology department. He is only for Foxy. I remember him as a Foxyer, and he has given so much from his end that we are always will remain to him. Every time, sir, you say something, we learn something. And sir has given lots to Foxyer. So we are really thankful to you, sir. And today also you are going to learn lots on fetal growth retardation. So when the expert is there, I think I am not supposed to say anything on the topic. So with this, of course, we have Dr. Geeta also as the secretary, and Dr. Mala Roy as an MOCA, and Sairam is our MOC, and all my dear friends. Very good evening to all of you. As I have already said, we all are committed to Foxy, and we are committed to women's health, and we are also committed to our babies, where we should give best of the life to them, because they are the tomorrow's generation. When they are born healthy, they are the future, and they will do the best if we give the best. So with this, I thank all of you for giving me this opportunity. Thank you.
Thank you, ma'am.
Okay, ma'am. Thank you, ma'am.
Can I have the CV of Kiran, ma'am?
Yes, ma'am. Yes, ma'am.
Kiran ma'am is the chairperson Medical Education Committee Foxy, and as a teacher for so many years, whenever I thought of joining a committee, immediately the thing stuck to me is the medical education. So we have so much pleasure in spreading the knowledge as a teacher, and Kiran ma'am is a HOD, former HOD, Department of OG Kanpur, and she's a peer reviewer of the Indian Journal of Obstetric Gynecology since 2021, and she has more than 36 years of teaching experience, and she is actively participating, as Dr. Tang said, in all activities of Foxy from 1988, and lots of research activities, and the President Appreciation Award for Adolescent Health Committee and Foxy Champion at IACOG. What more we need? She has received the Best Teacher Award. Ma'am, we are really happy to be associated with you, and Foxy is so proud to be associated with the Foxy Medical Education Committee. Over to you, ma'am.
Thank you, Dr. Vijaya, for the very kind words. At the outset, I'm very grateful to our dear President, Dr. Jaideep Tank, and Secretary General, Dr. Madhuri. Both of them are so humble and dedicated to the Foxy, and they committed so much that in spite of their busy schedule, they are always very important. So thank you, and thank you very much. It's really an honor to be with you all in the capacity of Chairperson Medical Education Committee, Foxy, and to organize this Oxy webinar with Oxy, that Aksharam. It's a unique sort of the word itself, and the initiative to that the monthly webinars for PG classes by the renowned teachers from all over the country is a very, very good initiative which has been taken by Dr. Vijaya. And actually, as you, Dr. Vijaya, you said, teachers have that, wherever they get a chance to read or to teach, they will be there immediately. So as soon as you said it, I said, I will be definitely be there, because that's my, you can say, passion. For a long time, we have been doing this. Still, I'm doing it. So that was the thing. So thank you very much, your team, Dr. Geeta, Secretary, Dr. Sairam, the co-chairperson of your MEC committee, Dr. Mala Raj, are all, I mean, excellent workers who will definitely plan with together lots of webinars. And today's theme, which you have taken, is also very out of box thinking. The minions do not need more care. In fact, actually, it's a very striking one, and specifically when it actually gives you the sense of profound responsibility for your tiniest patients, the one especially who are facing the problems of restricted growth. So that becomes additional. And the managing these FGR babies, I'm sure Dr. Suresh will be giving each and every point to our postgraduates, but we all know they need multi-special disciplinary approach. Not only the obstetrician, the maternal fetal medicine specialists, they have come a very good way to support us. The neonatologists, the other healthcare professionals, specialists, and then they have to remain into vigilance, continuous vigilance. That's the idea the postgraduates should go with it. That we don't have to, whenever such type of the situation comes, always involve all of your friends, because our ultimate aim is the well-being of the mother and well-being of the child, that small baby. That's what we need. And in this pursuit, I would say, also remember to be humble and compassionate. Besides that ultrasound machine, besides that doing the Doppler studies, remember that there is a mother who is fearful, who is worried. She can, with us, every word when we speak up matters to her, because she may get traumatized. She has come to us with lots of hope and lots of subconscious problems. So we have to be very careful. I only can say we should always remember that the humanitarian aspect has to be there. And in closing my words, I would just like to add, because I don't want to stand between this our postgraduates and the excellence, that the words of Sir William Osler once we said, the good physicians treat the disease, and the great physicians treat the patient who has the disease. And so let us strive together to become good physicians, not only good, but great physicians, so that we can endeavor and provide the utmost care to our mother, to our neonates. And with these words, I really wish that all the PGs, what maximum number of PGs join our courses and get benefited. And I'm sure Dr. Vijay will plan to have must be having recorded webinars also. Dr. Tank is very, particular, he likes uploading these the webinars for the benefit of the other Foxians also on the website. So if we will get, then later on also those students who will miss it can definitely get benefited. So that will be an added advantage of it.
Yes.
So thank you very much once again for joining hands with me, medical education. I'm sure, I am with you in all your endeavors, and we'll together do a long journey. Great.
Yes,
Thank you very much.
Thank you.
Thank you, madam.
Thank you very much, ma'am. Thank you, ma'am.
Thank you.
Now we'll go on to the main session. Thank you so much, President Madam, Secretary Madam, and all the chief guests. Now I want to introduce Dr. Suresh sir. Suresh sir is the doyen of fetal medicine in our country. And sir, actually, I would say he called the teacher of teachers. And nobody else is actually fit enough to talk about this. And sir will do the best justice to this topic. And we all know that sir is a director of Mediscan Systems, Chennai, and honorary secretary of VHS, Chennai, and also an adjunct visiting professor in perinatology, Ramchandra Medical College, and also an adjunct faculty in IIT Madras. Sir, over to you, sir. I'll stop sharing.
Yeah, thank you.
Thank you very much, sir. Thank you very much for.
Are you able to see my screen?
Yes, sir. Yes, sir. Yes, sir.
Yes, sir. Dr. Suresh, I'm also very keen to listen to your
Thank you.
lecture.
Thank you, ma'am.
Thank you, sir.
Good evening to all.
Welcome.
Good evening to all, and let me first thank Oxy for inviting me for this first session of this particular program that you have started. And also Dr. Jaideep Tank and Dr. Kiran Reddy, all those who said a few nice words about me. Thank you very much. And today the session is on growth restriction. And I want you to brace yourself, because what we plan to do is to take you through right from the fundamental aspects of fetal growth, the normal physiology of growth, then identifying growth restriction, and then seeing how to manage it, and then we'll come to the delivery point. Hopefully all our babies with growth restriction will be delivered safely.
It's a little more audible, sir. PGs have commented you're not audible.
Not able to see? Okay, 1 second. One second, I'll just check the mic. Yeah, mic was a little low.
Yes,
Now
sir.
it should be all right.
Now
right?
clear, sir.
Yeah. Okay, so let us start. What we are going to do now is to we want to give a brief introduction about fetal growth and the basic points. Then we look at placenta and fetal growth. We look at dating in pregnancy. We look at the growth charts, which and why. We classify growth disorders, early for fetal growth restriction, evaluation and Dopplers. Then we look at late fetal growth restriction identifying and management, and a unified approach to use Doppler in FGR. And then we'll try to sum up the whole thing at the end. So let's look at what are the factors that influence fetal growth. We all know that genetic factors influence fetal growth, and the maternal height, which actually reflects on the uterine capacity, and also the growth potential of the fetus itself, which influences fetal growth. So whenever I see a mother who's very short and see a baby which is less than the 10th centile, I'm not going to be too worried about it at that point. I will say most likely this is constitutional. The second thing we need to look at is the environmental factors, which today we also call it as epigenetic factors. Now, the birth weight of the baby is influenced by the woman who carries the baby. This is an important statement because there is no influence of the father's weight. So the father can be 120 kilos. If the mother is 45 kilos, the baby will be small. Then if you look at the donor ovum in IVF, the fetal weight is influenced by the gestational age and the recipient's weight and not the donor's weight. So the ovum came from the mother, from somebody else. It's growing inside another person. So the baby where the uterus is inside the uterus, which is growing, is that mother is going to influence the baby's weight. Then we also have to understand that there is a limited capacity of the uterus to support fetal growth. I'll tell that in a short while what it is, because this is to limit overgrowth and ensure future pregnancies are possible. Because if you allow unhindered growth of the fetus, almost all our human babies will be beyond 5 to 6 kilograms. That is the potential for the baby to grow. But there is a limiting capacity which makes the baby grow to a lesser extent, because we need to preserve the uterus for future pregnancies. Then there is limited availability of nutrients due to maternal size and increased demand. Especially in twins, for example, there is a more demand from the fetuses. The placenta can only supply this much, and the mother can only supply this much. So there is also some constraint of the growth. Now, what about maternal nutrient intake? It's extremely important because you look at diet, caloric intake, metabolic function, and maternal glucose levels we know are profoundly influence fetal growth. Low levels can cause small for gestational age. Classical example we can give you is tight control in diabetics. If you are very, very enthusiastic about controlling GDM, then you find the baby is growing small. Then you relax a little bit and the baby comes back to normal growth levels. And high levels can cause macrosomia. We all know about it. And the nutritional requirements, of course, vary with the gestational age. Now, let's now look at maternal uterine blood flow. It's extremely important because the uterine artery flow increases threefold over a period of time, and there is increase in the diameter of the umbilical artery, and there is decreased resistance to flow. And this we are going to identify with Doppler later on. The total uteroplacental flow is 25% of the maternal cardiac output. And new vessel development due to placental hormones, HCG and IGF-2 is well known. Maternal cardiac output increases by approximately 40%. There are profound changes in the maternal heart during pregnancy, and that's why we have to be careful about monitoring the maternal heart, and now they're recommending doing maternal echocardiography during pregnancy. Now, increased uterine blood flow is essential to meet the metabolic demand of the uterus, fetus, and placenta. So a fundamental thing is, as pregnancy advances, there has to be increased volume flow through the uterine artery. There also has to decrease the resistance to the flow. And the decreased resistance to the flow happens when there's remodeling of the spiral arteries into uteroplacental vessels. So how does that happen? Trophoblastic invasion and happens, and wherein the spiral artery loses its muscular coat, which causes increased flow. So we have a first wave of trophoblastic invasion, and we have a second wave of trophoblastic invasion, which comes in the second trimester. So the nutrient transport across the placenta happens through passive diffusion, facilitated diffusion, and also active transport. Now we are going to look at the relationship between the fetus, mother, and placenta, and this is extremely important for us to understand about the growth. Now, the mother, there is a maternal genome and maternal environment. Both these are going to influence fetal growth. There's maternal development, there's a maternal pregnancy state. As we said, there's increased uterine artery flow, increased metabolism and behavior, increased nutrient intake. So maternal health is going to be affected by smoking, undernutrition, and also hypoxia. So the next thing we are going to see is the placenta. Now, placental trophoblastic invasion, there is increased placental blood flow. There's growth of the placenta as the gestation advances, and there's increased hormone production, placental transporters, and also the glucocorticoid barrier. Now, the placenta, again, is related to the mother's growth, and the placenta are growing together with the gestational age as it increases, and there's influence between the two. Now, the maternal pregnant state actually promotes the growth. So the maternal pregnant state influences the placenta again contributes to the fetal growth. Now, what happens to the fetus? The placental function promotes fetal growth, but the maternal constraints limit the fetal growth. So on one side, you're having the baby growing rapidly, and the other side, there is a maternal constraint which is actually limiting the growth. And that's why babies we are seeing are limiting to a certain size. Now let's come to the fetus itself. The fetal, we know that there is a fetal genome which has its own genetic composition. there are imprinted genes that alter placental function, and there are also demand of the fetus for nutrition. So when the fetus demand nutrition, the placenta is expected to supply that nutrition. As a baby grows older, as the gestational age advances, there's going to be more and more demand. And the placenta has to respond equally by supplying what the baby requires. Whenever there is a discrepancy between the supply and the demand, this baby is going to be constrained in the growth. So that brings us to the question of placenta. The placental size is important. The placental weight to birth weight ratio, we know normal is 1:5 is to 1:7. It doubles from 24 weeks to term. The placental weight is an expression of placental efficiency. So the bigger the placenta is, or the more appropriate the placenta is for that week of gestation, the better the placenta is likely to function. Now, extremes of placental weight, there is higher risk of fetal demise. You see a very, very large placenta, or there's a very small placenta. Both of them are going to cause problems. Both of them are going to cause problems for the growth. The placenta receives and transmits endocrine signals between the mother and the fetus. So the placenta is beyond just transmitting the blood flow or oxygen. There also has endocrine signals which are going from there. Now let's look at thin placenta. When you have a very thin placenta, for example, in triploidy, the diandric type of the digyne type of placenta is thin. There's very early onset growth restriction. There's very low HCG and PAPA for the mother. And here you can see a very typical picture of a very large head and a small abdomen. And you can see the placenta is extremely, extremely thin. The diandric type of triploidy is more common, whereas there's a thick molar placenta. The fetal growth can be normal or can be growth restricted. So in triploidy itself, you have two types. One have a thin placenta, the other has a thick placenta. Right. Now, also sometimes you come across a very globular placenta. It's a small globular placenta. We call it as a small area of implantation. And there's this smooth architecture with absence of normal coarseness. There's a large amount of subchorionic fibrin deposition. If you tap on the placenta, it actually, you can see the subchorionic fibrin moving inside. We sometimes call it as a jelly-like placenta. And this baby delivered at 29-30 weeks due to altered Dopplers and certainly associated with growth restriction. Now, what about placental lakes? Placental lakes are actually anechoic, thin intervillous vascular spaces. Large placental lakes require close surveillance. You can see the blood flowing within the large lake. And there can be a thrombus in the placental lake referred to as the intravillous thrombosis. Because these are the most common sonolucencies, it has maternal blood. And color Doppler does not show any arterial flow, but slow swirling venous flow with when you keep the velocity scale very low. So large lake, when the lakes are very large, as you can see here, more than 5 centimeters, it is associated with small for gestational age, especially in the 3rd trimester scan. But majority of the lakes are harmless and they don't influence fetal growth significantly, and most of them will regress in the 3rd trimester. Now, subchorionic fibrin, on the other hand, can be quite troublesome. There is the material that is deposited are fibrin. The fibrin deposition is due to the stasis of maternal blood in the subchorionic area of the intervillous space, and there's massive subchorionic fibrin deposition may be associated with intrauterine growth restriction. So why I'm telling you all this is it's important to look at the placenta and look for any placental causes which is actually causing the growth restriction in a given fetus. So here you can see placental substance infarcts, and very typically you can identify the infarct by seeing the echogenic rim, which you see in the cystic area. There's no blood moving inside them. Blood is clotted there, but you can see the circle, and even in the autopsy picture, you can see the different color of that infarcted area which is there. So sometimes placental infarcts are difficult to diagnose on ultrasound, but this, if you see this typical picture, then we can certainly say it is there. Now, next, let us, having seen the placenta, let's go to dating the pregnancy, because dating the pregnancy is the most important thing before you can even identify a fetus with growth restriction. So when should we actually estimate the gestational age? Now, ISWAG has come out with a standard protocol for gestational age imaging, and I feel this is easy to adapt in our practice. Between 4 plus 3 and 5 plus 6 weeks, we do the mean sac diameter. That is length into breadth into width divided by 3. But we are not expected to date or assign EDD by just looking at the gestational sac. We don't do the mean sac diameter for gestational age estimation. Between 6 and 9 weeks, the crown rump length of 5 to 31.9 millimeters. Usually after about 7 to 8 weeks, you can use the crown rump length for dating the pregnancy, but the recommended time is between 10 and 13 weeks, 6 days. Where the CRL is 32 millimeters to 80 millimeters, it is the best time to date the pregnancy. Between 14 and 24 weeks, because if they have missed out the dating in the first trimester, between 14 and 24 weeks, we do the dating by head circumference and or femur length. We do not use the biparietal diameter for dating, and usually we expect the head circumference and the femur length to agree with each other. If there's a large discrepancy between the two, then we know one of them is abnormal, then we need to look at the fetus further. Now, after 24 weeks, we assess the size of the baby and not the gestational age. Now, let's look at a picture of dating in early pregnancy. As I said, we don't, especially never measure early pregnancy by transabdominal method. Always it has to be transvaginal, because if you see the sac here, if you do transvaginal, then you will actually be able to see a fetal pole, which you may not be able to see transabdominally. So it's prone to errors. So it's preferable not to use the transabdominal method. And here's the fetus at 8 to 9 weeks, where you can clearly differentiate the cephalic pole or the caudal pole. And the advantage of 8 to 9 weeks is the neck is still not formed. So there is no flexion extension that happens here. It's a uniform thing. And between 10 and 13 weeks, the fetus needs to be in neutral position, the fluid between the chin and chest, mid-sagittal position. They need to measure from the crown to the rump and make sure the measurement is reproducible and consistent. Now, when we measure the crown rump length, if the LMPGA and the crown rump length, there's a difference of more than 5 days between 8 to 11 weeks, we would like to correct the expected date of delivery. If it's more than 7 days, between 11 to 14 weeks, if it's more than 7 days, we'd like to correct the expected date of delivery. Now, what if the LMP is unknown or she is not sure? And in such cases, we go directly by CRL measurement. CRL is used for dating, and that's fixed at that point. Now, what about ART pregnancies? Now, ART pregnancies, you can have date of embryo transfer could be day 3 or day 5. So let's look at how we do it. The embryo, because it's an embryo, because already fertilization has occurred, it already has an age assigned to it. The date of fertilization, age counting starts. The day the egg is fertilized, now that is the day this baby is now going to start its birthday. You can call it as the birthday of the fetus. Now, date of transfer is or may be different. So if you have, our whole calculation is we must come to 266 days, because from LMP date we take 280 days. The 14 days does not count when in the IVF. So you take 266 days. From day 3 embryo transfer, you add 3 plus 263 days. Day 5 embryo transfer, it is 5 days plus 261 days. So ultimately you add up, it will become 266. That's what happens. Now, what do we do? Once we have a crown rumpling and we want to assign gestational age to the baby, just to remember that this patient has come to me and says, Doctor, I am pregnant and I think I'm pregnant 3 months. And you're going to say, well, tell me your LMP. She says, I don't know. She's not an IVF patient, because all IVF people, we don't need to bother about the LMP. We don't need to bother about the crown rumpling. It's the IVF date, which is going to stand as the gestational age. Now, when we have a crown rumpling, what we are going to do is, I have a measurement and I am going to presume that this baby is growing on the 50th centile. All babies, I will presume they are going on the 50th centile. It is a presumption. Even though this baby could be on the 5th centile or the 95th centile, I'm not going to worry about it, because the variability at the crown rumpling time, gestational age of 12, 13 weeks, the variability is very, very small. It is not going to influence our delivery date very significantly. So we say, if the crown rumpling is 54 millimeters, I'm going to assign a gestational age of 12 weeks. And once I assign the gestational age of 12 weeks, this gestational age, and I will predict an EDD from this stage, and all my other scans where I identify the growth of the baby is going to be based on this assumption. Now let's go to the second trimester. And how do we estimate gestational age? By head circumference and femur length. We follow the same principle because we don't know the gestational age, and we take the head circumference and I plot it on the 50th centile and say, because your head circumference is
Is it clear that visuals, Chitra? Hello, Chitra?
Yes, ma'am.
Is it everybody able to see it? It's a
Yes,
little
ma'am.
dark. No?
Yes, madam.
I can see, ma'am.
How is it the clarity?
Yes, perfect, ma'am.
Madam, தெரியுது.
Okay.
Okay.
Madam, தெரியுது, madam.
We can see it properly.
Yeah.
Okay. So in the second trimester, I'll follow the same principle. If the length of the femur, let's say 170 millimeters, I'm going to say you are 19 weeks and 6 days. I'm going to assign this. And if there's a discrepancy between the head and femur, I'm going to check the parents and I'm going to take a different route altogether. Now, let me show you this graph, and which we need to now make a differentiation between what is dating and what is growth. And dating means you are assigning an age for the baby. Growth means how much the baby has grown for that period of gestation. Now, how do we do that? Now, let's say this patient is coming for the first scan and is going to be dating. So I know the measurement. Measurement is 160 millimeters. Okay. Then 160 millimeters corresponds to, let's say, 20 weeks or 21 weeks. Right. So 50th centile dating is done. Now I'm going to tell the patient, well, you come back after 10 weeks and I'm going to rescan you. When she comes back after 10 weeks, 10 weeks later, I already know she's 30 weeks because I had given her a gestational age of 20 weeks. I know she's 30 weeks. So I'll draw a line from the x-axis to the graph. And then I will also have a measurement I would have done. So I take that measurement and I will find when these two lines meet and say it goes on to 70th centile. So I'm going to say, how much have you grown is the question I'm going to ask. The baby is now growing on the 70th centile for 30 weeks. So I assumed on the 50th centile. Now the baby is growing on the 70th centile. So this is as close to the truth as we can get in the process. Right. Now, the other measurement which we would like to do is the transverse cerebellar diameter. The transverse cerebellar diameter in millimeters is equal to gestational age between 14 and 20 weeks. So generally, the transverse cerebellar diameter does not participate in the growth restriction process. There is a chart available throughout the pregnancy, and it can be used when you're having all other parameters are going haywire, you can use the transferable diameter. Now, the most important thing is this. All the ultrasound machines have this facility. The moment you put BPD, it's going to say gestation rate 23 weeks, 5 days, 90.8%. Femur is going to say. So according to BPD, this baby is 23 weeks and 5 days. According to femur, she's 21 weeks and 2 days. And according to AC, she's 22 weeks and 5 days. So you can see different gestational ages from the same fetus. They're not all equal. They are unlikely to be equal because head, abdomen, and extremities are growing in their own proportions. There is a reasonable body proportion, but all of us have different sizes of head, abdomen, and femur as we know it. So that's why the fetus also has a discrepancy. So there's a small variation which we want to accept. And because of this concept of variability in not only the entire fetus, but individual components of the fetus, we have difficulties in identifying which baby is having growth restriction or no. But there are 3 things which you should never do. Do not date too late in the pregnancy. Do not change the dates once assigned early. And do not use machine values blindly. So if this patient is coming to you for a second time or a third time, where already dating has been done, if you just copy this number and put it in your report, you will be completely wrong because date could have been corrected, but this will not go according to corrected dates. This will go according to what the chart is giving inside, and it not be appropriate for the patient. So we need to be careful about that. Now, the most important thing next I'm going to tell you is to optimize the biometry. Now, let us look at in the biometry. Remember that the head of the fetus and the femur are both bony measurements. They are hard measurements. The endpoints are very clearly seen, and it is easy to do that measurement. But when you want to measure the abdominal circumference, the caliper must be outer to the outer measurement. And the abdominal circumference section should be a transverse section where you see the stomach, you see the C curve of the portal vein, for the umbilical vein should not touch the anterior-abdominal wall, and enough fluid around the baby so that the borders are well seen. And then we can measure the abdominal circumference. Now, why I'm saying this is because this is a example of a fetus, a single fetus where we have made the measurements 270 millimeters, 297 millimeters, 285 millimeters, and 262 millimeters. The same fetus I have measured, all of them abdominal circumference section, and each one of them has given me completely different measurements. If you give a little pressure on the probe, it will give you a different measurement. And this is the main reason why when ultrasound predicted or estimated fetal weight is given, let's say they've given the weight as 2.8 kg, the baby is born 3.6 kg. This measurement, because even a few millimeters difference in the abdominal circumference will increase the inaccuracy of measurement by more than 500 to 600 grams. So that's why the abdominal circumference measurement is the single most important measurement to diagnose growth restriction. At the same time, it is also the most difficult measurement, so reproducibility has to be ensured. Now, so here's the femur measurement which we are doing, and the femur again has to be measured properly, because if you look at the femur, you can see small artifact jutting out of the femur end. And most often, if that is measured, the femur will falsely look larger when actually it is not. So the diaphysis length must be identified correctly. So you can see how this caliper is placed in the wrong position, whereas this caliper is placed in the correct position. So optimizing biometry becomes absolutely important. Once you're sure of a biometry, then we can calculate the estimated fetal weight. There are several formulae for estimating fetal weight, and entire world, if there is one thing they agree on, is the Hadlock 3 formula is the most reliable formula, right? And that is the predictability is plus or minus 12%. Now, the caveat is you must have done the biometry correctly. If you have done the biometry correctly, use the Hadlock 3 formula, then the estimated fetal weight is probably closest to the truth. Now, see, you can see how the difference is. This, if by just placing the caliper between 310 millimeters and 322, the estimated fetal weight has gone from 2,299 grams to 2,837 grams. That is the amount of 538 grams is the difference that can be there. So be careful. Now, next we look at growth charts and patterns. Now let's look at normal fetal growth. So we have identified biometry now. We know the dating. Let's look at fetal growth and what influences fetal growth. So I'll just. So normal fetal growth, we already said there is a predetermined growth potential for the baby. Every baby has its potential to grow. There is maternal health we spoke about. There's placenta we spoke about. And so now what is it? As we said, there is a huge variation in the birth weight. If you take 100 women, all of them exactly of the same weight, same gestational age, they are all delivered on the same day, you'll find there's a huge variation in weight because 30 to 50% maternal genes and the environment also influences. So now we need to show how fast the baby is growing. We call it as fetal growth velocity. It's a rate of growth over a given time interval and the rate of change of BPD, HC, ACFL over a period of time. So what is going to happen is there is an initial peak between 13 to 16 weeks, there is a rapid growth. And then around 20 weeks or so, 22 weeks, there is a rapid acceleration, which we call as the second acceleration. And then, of course, the growth slows down during the last month. Now, for us to understand this easily, between 14 and 15 weeks, the weight increase in the baby is about 5 grams per day. At 20 weeks, it's about 10 grams per day. At 30 to 34 weeks, it's about 30 to 35 grams a day. And estimated fetal weight, growth velocity peaks around 35 weeks or so. So we can plot this entire growth. We identify the growth by plotting it on a growth chart. And here you can see there are several, by just looking at the visual effect of the growth chart is so profound that you can easily identify whether this baby is growing normally or no. So this baby is showing, you can see the growth curve of the abdominal circumference. You can see it on the lower centiles. Sorry, I'll just one second, something. One second. Okay. It's got hidden. Okay, so this is growing on the lower centiles. So we call it as a low profile fetus, small for gestational age fetus. So when the baby is maintaining its growth curve, even though it is small in size, it's growing on the 10th centile, you're growing on the 5th centile. As long as it is growing along the same centile, we do not call it as growth restriction. We call it as low profile growth or small for gestational age. And then, of course, we look at Dopplers. We'll see how we interpret it with Dopplers. The second important thing to understand is some of these babies can have a sudden catch up in growth. So this baby was growing along the 5th centile, and suddenly when it came to the 3rd trimester, start growing up. That's because maternal nutrition. She was a working mother, working very hard, not taking any rest at all. And then when we put her to rest, then you can see the baby growing up very well. This is called as catch-up growth in the 3rd trimester. The next is this pattern is very, very obvious, where you can see as the abdominal circumference, as it goes down around 24 weeks, you can see the growth curve falling off the curve. Now the growth curve is falling off, and that means this baby is getting growth restricted. You can see it in the abdominal circumference, you can see it in the head circumference, you can also see it in the femur length, and also the estimated fetal weight is below the 5th centile. So, but because the growth is falling off at a very early gestational age at 21 to 22 weeks, then we call this as early onset fetal growth restriction. Then we also need to understand that along with your biometry, we also do Dopplers, and Dopplers must also be plotted on the graph. It's not enough if you give the Doppler saying there is absent diastolic flow or the positive flow or increased diastolic flow. We need to plot it on a graph. The pulsatility index of the umbilical artery and the MCA should be done, and the ductus venosus, and they are plotted on a graph and see whether they are normal for the gestational age. Now, once we have the biometry, we need to interpret the biometry by using the growth charts. Now, there are several growth charts which are available, and there's always been a controversy which charts to use. The WHO study found substantial differences in fetal growth between various countries, and they concluded that populations, even under optimal nutritional conditions and environment, vary, and that fetal growth varies and should be considered when the WHO fetal growth, any growth references are applied. So if you use a universal chart, like the Hadlock's chart, for example, and you use it universally, it will give you a misclassification of fetal growth restriction. So they recommended that the chart should be adjusted to each country and a local population. So also FIGO position also said local or regional charts are likely to be best identify the 10th centile of infants at higher risk. Now, if you use the WHO intergrowth chart, use the 3rd or 5th centile and not the 10th centile as the cutoff. By classical definition, fetal growth is supposed to be small, baby is supposed to be small when the estimated fetal weight is below the 10th centile. But if you are using an inappropriate chart, instead of using the 10th centile, use the 5th centile, because otherwise you'll be calling too many babies as growth restricted when they are not. Now, that brings us to the question of how are we going to define fetal growth restriction. Now, failure of the fetus to meet its growth potential due to a pathological factor. Very, very important is the pathological factor. Because a baby can be small just because it decides to be small. The mother was, when she was born, she was only 2.2 kg. The mother now is only 35 kilograms or 40 kilograms. She is not expected to produce a very big baby. So when there's a pathological factor, then we call it as growth restriction. The most common etiology being placental dysfunction. And we define small for gestational age when the estimated fetal weight is below the 10th centile and for gestational age. Now, fetal growth restriction is estimated fetal weight below the 10th centile, but there's a pathological component to it that we'll have to identify. How are we going to differentiate between a constitutionally small baby and a pathologically small baby? So here is what growth potential actually means. So here's a graph where the baby's expected size, and this baby is smaller than what is expected, the first baby, and the second baby is also small. So it is expected to grow on the 90th centile. It is growing on the 50th centile. That itself is abnormal for that baby. If the baby is expected to grow on the 50th centile, it comes down to below the 10th centile, then we call it as abnormal. So it's a relative term based on the growth potential, and this is the reason why, since we don't have very clear methods to identify growth potential of every baby, many of these IUGRs the diagnosis becomes very difficult. Now, once we come to the concept of early onset growth restriction, we call it as a placenta-mediated fetal growth restriction. We'll talk about placenta-mediated fetal growth restriction, and we divide that into two groups. One which happened early. When I say happened early, it means before 32 weeks. It's about 0.5 to 1% of all growth restrictions. Estimated fetal weight or abdominal circumference less than the 3rd centile, or umbilical artery with absent or reversed end diastolic flow, or estimated fetal weight or AC below the 10th centile, combined with umbilical artery more than 95th centile, or uterine artery PI more than 95th centile. Now, what it actually means, if you simplify it, if you have either an abdominal circumference or estimated fetal weight, which is below the 3rd centile, irrespective of the Doppler, this baby is fetal growth restriction. I'm not going to call it as a constitutionally small baby. Now, if the baby is between the 3rd and the 10th centiles, now, if the Dopplers are normal, I'm going to call it as a constitutionally small baby. If the Doppler is abnormal, then I'm going to call it as pathological fetal growth restriction. That's what the Delphi criteria says. Now, late onset growth restriction is after 32 weeks, estimated fetal weight or AC below 3rd centile, and any two or more than two of the following criteria. AC or EFW less than 10 centiles, AC or EFW crossing greater than 2 quartiles on the growth percentile. This is very important because we are going to see a baby after 32 weeks. This baby has been growing well till now. At 28 weeks, you did the scan that it was on the 40th centile. So he said everything is fine. And suddenly, when you come to the 32 weeks, the baby has gone down to the 5th centile. Or the baby has been growing on the 80th centile, and suddenly it has come to the 20th centile. So it crosses to, when I say 2 quartiles, 50th centile, 25th centile, 10th centile, as it moves down forward. Or the cerebroplacental ratio less than 5th centile, or umbilical artery greater than 95th centile. We'll talk about cerebroplacental ratio as we go along. But most important to remember is there are different phenotypes of fetal growth restriction. It's not like fetal growth restriction, there's only one type. There are several types, which we will see. So that brings us to the question, why is this baby growing small, right? History of stillbirth. The risks of FGR is stillbirth is one of the important risks that are there. Preeclampsia, placental abruption, and preterm birth. Now, neonatal risks, there are short-term and long-term risks. And this is what we need to be very, very cautious about, because this is where the chain gets broken. And we are conscious of the fact that this baby could have long-term consequences and not only short-term. Now, neonatal mortality, morbidity like hypoglycemia, bilirubemia, hypothermia, adverse outcome in the NICU stay, these are short-term. Now, once the baby comes out of the NICU, they say baby has graduated from the NICU, given to the mother started feeding, and everybody smiles and goes home. And then everybody forgets about that baby. Now, important thing is neurodevelopmental outcome must be done. All babies which are identified as small babies in utero must have a neurodevelopmental assessment at 2 years of age. And this is something which you should weave into our practice and encourage people to do that. And of course, the long-term morbidity of metabolic syndrome, obesity, cardiovascular disease. Now, there are several maternal factors which contribute to fetal, and maternal hypoxia, autoimmune disease, hypertension, blood sugar, hypercoiling of the umbilical cord also has been shown to be associated with growth restriction, or genetic factors like, as I told you, like triploidy and other conditions. Now, that brings us to the question of, there is an issue we spoke about. There is a placenta in between, which is actually supporting fetal growth. And what is it doing? When there's a normal perfusion, there is normal diffusion of oxygen and carbon dioxide. Now, when there's early onset growth restriction, it's an abnormal perfusion, and that abnormal perfusion leads to decreased oxygen diffusion and increased carbon dioxide diffusion. So this abnormal diffusion happening early in pregnancy is going to have a profound effect on the fetal growth. Now, when you come to late FGR, this placenta has been doing quite well all along. It has been doing quite well all along, and it grew in size. The number of tertiary villus arteries were also normal, and the perfusion was initially normal, but there's abnormal diffusion alone. For some reason, late placenta shuts down, and it says, I'm good in structure, but I'm not good in function. And that's why that becomes more difficult to identify as compared to the early onset growth restriction. So because the placenta is the one which is involved, if you look at this graph, it will tell you that the darker bar is umbilical artery abnormal. The lighter bar is umbilical artery normal. So here what happens is that the number of the darker bars are more in early onset growth restriction as compared to late onset growth restriction. Agreed? Late onset, the darker bars are lesser, which means the umbilical artery is going to be normal, more normal in the late onset growth restriction as compared to early onset growth restriction. So because of villus paucity, umbilical artery shows high resistance. In late onset growth restriction, there is villus edema and immaturity. So diffusion alone is the one which is affected. So now we need to come to identifying this small baby. And for that, we are going to use Dopplers. The question is, are we going to use Doppler for everybody? We don't do Dopplers for everybody. We need to know when to do the Doppler and how to interpret the Doppler. So if you look at the risk factors, we can divide the risk factors into minor and major risk factors as given by the RCOG. And there's a list. I don't want to go through this list, but there are major risk factors and minor risk factors, which means when we take maternal history, we are expected to take all this information down. Because the moment you take the history and you tick off these risk factors, you straight away triage that patient saying this patient is a high-risk patient for growth restriction. How is that thing applied? When there are 3 minor risk factors, you do a target scan and uterine Doppler at 20 weeks. And if it is normal, you just do a late 3rd trimester scan with growth and Doppler. Now, if the target scan at the uterine artery Doppler is abnormal, then serial monitoring of growth and Doppler from 28 weeks onwards. So essentially what we are using is the 2nd trimester uterine artery Doppler. If it is showing high resistance, we are telling the patient you come back at 28 weeks. If it is absolutely normal, we say you come back after 34, 35 weeks. So we'll see that time in a short while. But if there's one major risk factor, irrespective of whether the target scan the uterine artery Doppler is normal or abnormal, she needs to come from 28 weeks onwards. So that's why history becomes very, very important. You take the history and decide whether she needs a 28-week scan or a 34-week scan. Also, if there is maternal obesity or very large fibroids, they are already at risk and they need to come from 28 weeks onwards. Now let's move on to early onset growth restriction. How do you evaluate and how do you monitor? Now, estimated fetal weight less than 10 centile, normal umbilical artery Doppler, we are going to call it as constitutionally small baby. Now, when there's an abnormal uterine artery Doppler, we are going to call it as fetal growth restriction, placental insufficiency, and this baby has a completely different pathway for surveillance. And that's the pathway we'll discuss now. Now, so there is a 5-point checklist for early onset growth restriction. First is history. Second is structural anomalies, hydrops you need to rule out. Placentomegaly calcification need to rule out. Leica and Doppler, and placental histopathology after delivery. Now, you may have a successful delivery, but it is important that the placenta is studied histologically to look for whether there was a placental cause for this baby to be small. Now, the placental phenotype, hyperinflated or small placenta, high resistance uterine, low PAPA, low PLGF, high HCG. All these will constitute saying that this placenta is not normal. We discussed about that early. So I'm going to show you this case where you can see very early onset growth restriction, baby graph is falling off, and you look at the uterine artery Doppler shows very high resistance flow. And then all the parameters, she is 23 weeks and 3 days by age. All parameters are 19, 20 weeks, and it's below -2 standard deviation. So this means this baby is early onset growth restriction abnormal uterine artery Doppler, and you look at the umbilical artery Doppler showing reverse diastolic flow. You see the ductus will also showing high resistance flow, and you can see middle cerebral artery showing increased diastolic flow, and that this is something, these are the changes we expect in Doppler. Now, when we looked at the placenta, so we're saying, why is this baby small? Then we looked at the placenta, you can see a huge amount of subchorionic fibrin deposition. So instantly we were able to conclude that this baby is small. You can see a very large subchorionic fibrin deposition there. We were able to conclude that this baby is having a fetal growth restriction because the placenta is abnormal. So we got the etiology. Now let's look at whether screening can be done. How early we can screen for growth restriction, and whether it's a possibility to prevent the growth restriction from happening. So optimizing maternal health, treat the hyperemesis and improve maternal nutrition is probably the one low-hanging fruit we have, which we should always look at. We can also evaluate and screen for preeclampsia. 70% of early FGR is associated with preeclampsia. You look at uterine artery Doppler, the mean PI greater than 2.4 in the second trimester, PLGF less than 0.7 mom, PAPE less than 0.4 mom, and HCG is greater than 2.5 mom. So you have some biomarkers, you have some Doppler markers, and you have some history. So important to know that uterine artery should be taken in the correct fashion, where you actually do a mid-sagittal view of the just above the pubic symphysis. You move the probe using the color Doppler, and then you see the uterine artery which is coming there. And once you place the Doppler sample of a 2 millimeter gate, it will give you the Doppler waveform. And once you get a waveform, adjust the pulse repetition frequency. And once you get a clean waveform, we are expected to measure it. So now I'm actually going to zoom the image so that we ensure we are exactly in the place where we want. So you need to do so many adjustments to get a proper uterine artery Doppler. Now I'm going to zoom the image there. You can see a zoomed image. Then I press the pulse wave Doppler and I reduce the sample volume width to 2 millimeters. And then I switch on the pulse Doppler, and you can see the Doppler, which will come in a second. Now I have to adjust the baseline so that it comes to the normal level, and then you have a uterine artery waveform. So important thing again is do the correct technique. So how do you calculate? You do always both uterine arteries, right uterine artery PI, left uterine artery PI, and you take the mean uterine artery PI. As I said, 2.4, more than 2.4 is abnormal. Right. Don't worry about the diastolic notch, which usually people say. Only PI is important. So you can see the normal flow and high resistance flow. Now, when you do first trimester uterine artery Doppler, 73% of increased PI in the first trimester normalized in the second trimester. So at first trimester, when I do a uterine artery Doppler, oh, it's abnormal. But when you come to the second trimester, nearly 73% of them will become normal. Now, why this happens? Because at the first trimester, we have just finished the first wave of trophoblastic invasion. Then the second wave of trophoblastic invasion takes later. So uterine artery Doppler sensitivity is better in the second trimester than first trimester. But unfortunately, if you do it in the second trimester, it is too late to give aspirin to the baby, so to the mother. So that's why you need to do it in the first trimester, even though the false positives are a little bit more. Now, supposing there's an increased PI in the first and second trimester, then there's a higher risk of adverse outcome. And normal PI in the first trimester has got the lowest risk of adverse outcome. So in the first trimester, the negative predictive value of Doppler is extremely good. So if you say normal PI, then the less chances that this mother will develop preeclampsia. So here's a case study where the baby, the mother, they did a biochemical screening for Down syndrome. that showed low PAPA, low PLGF, mean uterine artery PA was high, and the P risk was given as so should be started on low dose aspirin. Now, the question now comes is, should we screen early for FGR for all patients? Now, at this point, this is the consensus which has come. There is no role for routine screening with serum biomarkers for FGR. However, when biochemical markers are available as part of prenatal genetic screening for trisomy 21, it may be reasonable to use this information for the purpose of risk stratification for FGR, right? Now, low PAPA below 0.4 mom, low PLGF 0.7 mom, high AFP 2.5 mom, high HCG above 2.5 mom. Now, what this statement actually means is, you don't screen for FGR, but we screen for preeclampsia. Okay, we screen for preeclampsia, but we don't screen for FGR, correct? Right. So when you look at screening for preeclampsia by the same factors, we are able to identify 90% of early onset preeclampsia, 75% of preterm preeclampsia, 41% of term preeclampsia with a screen positive rate of 10%. So the aspirate trial, where the aspirin reduced the risk of preeclampsia before 37 weeks by 62%. And before 34 weeks by 82%. And that's why it makes a lot of sense to screen for preeclampsia in the first trimester. Right. And also, the screen positive group showed that there's a higher incidence of small for gestational age babies. So it's a secondary kind of a thing. You screen for preeclampsia, some of them will be small for gestational age also, right? So aspirate trial, the use of aspirin reduced the overall incidence of SGA less than 10 centile by 40% in babies born before 37 weeks and by 70% in babies born before 32 weeks. So aspirin actually helps you to reduce SGA also, not only preeclampsia. Right. Now, what about low molecular weight heparin? Now, this paper looking at intrauterine preeclampsia and growth restriction in women with a history. There was a randomized trial. They looked at standard care versus additional low molecular weight heparin. The relative risk of preeclampsia of 23 to 25%. It showed no beneficial effect of low dose aspirin used in pregnancy to reduce risk of recurrence of preeclampsia and SGA. So in previous history of preeclampsia, you start the patient on low molecular weight heparin very early in pregnancy. It has been shown to have no beneficial effect. In practice, we see a lot of patients who are being prescribed this one, but it doesn't seem to have any evidence for that. So here's the second trimester uterine artery Doppler showing abnormal high resistance flow. Now, how are we going to now build this? So we go back to the Delphi criteria and say you are using this uterine artery Doppler in the Delphi criteria to identify this baby's growth restricted or whether it's small. So now we have a baby with early onset growth restriction. What are we supposed to do? Now you've taken the history, you've taken the family history, you've taken the history. Two important things. One is fever with rash and history of any infection exposure and previous history of a low birth weight baby. Now we also do TOT screening and rule out. We just look for autoimmune disorders history. We don't. Which we need to rule out CMV, toxo, rubella, and malaria. So that brings us to the question of doing umbilical artery Doppler. Now, umbilical artery Doppler, we start doing from the second trimester in babies which are below the 10th centile. Now, if the baby is growing on the 50th centile, there is absolutely no role for doing umbilical artery Doppler. Because when we do the umbilical artery Doppler, sometimes it's a dynamic thing. So you may get suddenly one high resistance flow when the baby is having a normal growth You may have a high resistance flow, and we may rely more on the Doppler than on your biometric measurements. So it's important to say that your biometry and the Doppler must actually coincide with each other. It's important. And then you say, okay, here's an abnormal Doppler. So what are the abnormalities in the umbilical artery Doppler that you can get, right? First is whether there is forward flow in the umbilical artery during diastole. That's the first picture you're seeing. The second picture shows absent end diastolic flow. And the third picture shows reversed end diastolic flow. Now, what does it mean? When there's reversed end diastolic flow, it shows almost more than 70% of the tertiary venous arteries are occluded, and absent end diastolic flow shows more than 60% of tertiary venous arteries are occluded. And when there's still forward flow, till about 40 to 50% of the tertiary venous arteries being occluded, still the Doppler will show forward flow. Now, so umbilical artery identifies degrees of impact placental function. It provides diagnostic and prognostic information. It helps reduce perinatal mortality and morbidity. And the transition from absent end diastolic flow to reverse end diastolic flow may be slow and gradual in early FGR. So absent diastolic flow does not mean delivery immediately. So we need to be very careful about how we are going to use the umbilical artery Doppler to time the delivery, which we'll see presently. But when there's a reverse diastolic flow, the perinatal mortality of 50% is there, and also that's a higher long-term sequelae. But then we have another important vessel to look at, because both the umbilical artery and the uterine artery are placental vessels. They are not fetal vessels. They are looking at the placenta. The ductus venosus is a fetal vessel. And what does the ductus venosus do? That the blood is flowing through the ductus venosus into the right atrium, and the flow in the ductus venosus is dictated by the pressure in the ductus right atrium. Normally, whatever be the gestational age, the ductus venosus pressure will always be higher than the right atrial pressure. The ductus venosus pressure will always be higher than right atrial pressure. So the picture below tells you that you can see the typical M pattern. Getting the yeah. Okay, so you can see the typical M pattern which is there. That's showing the lowest point in the ductus venosus is called as the A wave, or the wave of atrial contraction. Now that is showing forward flow. If they're showing forward flow, that means the ductus venosus pressure is higher than the right atrial pressure. But in the picture which you see above shows a small reversal of the A wave. That means the right atrial pressure is higher than the ductus venosus pressure, and that's why there's reversal of A wave.
Sir, you can take a break a few minutes, sir. You want water or something?
No, I'm okay. I'm okay.
Okay, sir.
So here you can see various patterns of ductus venosus waveform: normal, absent A wave, reversed A wave. There's a decreased V wave, and also there's a M shape, that very deep A wave is also there. So all these are very ominous. Right. Now, what does it do? Ductus venosus assesses cardiac status. Its increased resistance versus DV reversal is what we are looking at. It is the single strongest marker to predict short-term risk of fetal death. This is what we are very worried about, isn't it? In a growth-restricted baby, is this fetus going to die? And how long is it going to take for it to die? The risk of stillbirth is 20%. The odds ratio is almost 11.6. The risk of stillbirth with strict monitoring protocol with a safety net, elevated DVPI, it's only 2%, and absent or reverse A wave is 4%. In other words, you can reduce the risk of stillbirth from 20% to 4% by just monitoring the ductus venosus and timing the delivery appropriately. But then we also have, let's go beyond the ductus venosus and look at the umbilical vein. The normal umbilical vein has got a smooth flow, which you see there, low velocity, smooth flow. But in the presence of cardiac dysfunction, the umbilical vein also becomes pulsatile. You can see it's also giving an M pattern almost like the ductus venosus, so which is not supposed to happen. That pulsatile umbilical vein means this baby is going to die very, very soon. Right. Then we look at late fetal growth restriction. So we've seen early onset fetal growth restriction before 32 weeks. Doppler changes are going to happen, umbilical artery change, the ductus venosus change. We are not speaking about middle cerebral artery in early onset growth restriction. Deliberately, I left it out because I'm going to come to late onset growth restriction and tell you the use of the middle cerebral artery. Now, the definition of late onset growth restriction means FGR greater than 32 weeks. Again, we have seen that already in the one of the earlier slides. So now this baby has come to after 32 weeks. We have to do growth scans. We have to use growth charts. The point is, when do we do it to have optimal outcomes? What cutoff do we use to determine a problem? And do we need to do routine Doppler? So these are all very difficult questions to answer because more than 50% of late onset growth restrictions will go unnoticed in spite of scans, right? So should we do a universal growth scan? That's the question. There will always be a controversy whether third trimester scan is required or not required. And there are still papers which say that routine third trimester scan is not useful, is not indicated. And but this paper showed in 2015, showed it tripled the sensitivity of SGA detection and more than doubled the detection of severe SGA. But we don't need to argue whether third trimester scan is necessary or not necessary because in our population, almost everybody will get a third trimester scan. But the question is when to do it, which is the most appropriate time to do it. In a low risk patient, as I told you earlier, you do a scan at 34 to 36 weeks. In a high risk patient, you do at 26 to 28 weeks. What do I mean by high risk? Low PAPE, high resistance uterine artery Doppler, low growth profile in the AC or EFW, prior fetal growth restriction, maternal disease, all of them I'll call them at 28 weeks as we have spoken earlier. Now let's look at the question of stillbirth, right? Now before 32 weeks, small for gestational age baby, stillbirth is 4%. Between 32 to 36, it's 11%. More than 37, it increases to 70%. That's why we don't want SGAs to go beyond 37 weeks. That's because a higher chance of dying, isn't it? But the neonate SGA in stillbirth, less than 32 weeks, out of 4% is almost 70%. And beyond 37 weeks, it's about 30% or so. The message here is simple, that small for gestational age babies, as growth restricted babies, as they go more and more into gestation, more likely to die. Now, why they are more likely to die? Because the placenta is not able to supply. There's a huge demand. The demand versus supply is going to discrepancy is going to so high that the demand will outstrip the supply totally, and the baby will not be able to survive. Simple. So, in 55% of antepartum stillbirths, fetal death occurred after 32 weeks of gestation. Birth weight was less than 10 centile for GA in 38% of the cases. Right. Now, the tools for identification. How are we going to identify this late onset growth restriction? We have growth velocity, which we show the growth chart. We have uterine artery Doppler, umbilical artery Doppler. We also have cerebroplacental ratio, and that's what we are going to highlight on. And of course, we have venous Doppler, cardiac functional changes. Now, this uterine artery Doppler is a little question here, because so long everybody has been saying that uterine artery Doppler is used in the second trimester just to know whether she's at risk or not risk. And once it's over, it's done and dusted. You're not going to use uterine artery Doppler to time the delivery or to follow the patient. We don't do serial uterine artery Dopplers, right? But whether the third trimester requires or not requires, we'll see that. But we will definitely do middle cerebral artery Doppler. Now, the middle cerebral artery Doppler also has to be done by a proper technique, because unless you get a proper waveform, then it will not be interpretable. So you can get an axial view of the head where you go to the base of the brain and you see the red vessel going towards the probe. And one of the good things about that is it is almost parallel to the Doppler line. So the angle of Doppler will be near 0 degrees, and that is a very, very good angle for Doppler in any vessel. So I sample it close to the origin, and then I adjust the sample volume to about 2 millimeters, and then I press the Doppler button. Thanks. Now here you can see the middle cerebral artery showing absent diastolic flow. It's a little alarming, isn't it? Now middle cerebral artery, the lower the diastolic flow, the better it is. Nothing to get worried about. This absent diastolic flow comes because you give a lot of pressure on the head, it will show absent diastolic flow. You just release the pressure for a little bit, then it will go away. Now, what is abnormal in the middle cerebral artery? The middle cerebral artery abnormal, the peak systolic velocity and the end diastolic velocity and the pulsatility index are calculated. In growth restriction, when there is an oxygen lack in the baby, there is opening up of the cerebral vessels because of cerebral autoregulation, and there's increased diastolic flow while the systolic flow remains the same. So systolic flow remains the same, diastolic flow increases, so the pulsatility of the middle cerebral artery will go down. So in hypoxia, you will get marked increase in the diastolic flow with no increase in the systolic flow. Right. Now we have umbilical artery Doppler, PI, which we have already done. We also have middle cerebral artery Doppler, which we have done. And then we make a ratio of both called cerebroplacental ratio. So MCA PI divided by the umbilical artery PI, it detects redistribution of blood due to two mechanisms. One is called as forced centralization due to increased placental resistance, and second is decreased cerebral resistance due to brain sparing. So there is increased placental resistance. So the baby says, I want my brain to survive. So it is trying to push the blood more to the brain, and the brain responds by saying, okay, I will dilate and allow more blood to come through. Now, the important thing about the cerebroplacental ratio is, if you look at all the Doppler parameters, the umbilical artery, the middle cerebral artery, and the cerebroplacental ratio, you find the cerebroplacental ratio deviates maximum from the center point. You see the graph going wide. The wider it goes, the more sensitive it is. So this wide variation in moving away from the thing tells you that among all the parameters of umbilical artery, middle cerebral artery, and CPR, CPR is the most sensitive parameter to identify fetal hypoxia in the third trimester in late onset growth restriction. So that means, does it add value in our surveillance? Because the CPR is decreased even when the umbilical artery and MCA values are very close to normal. So when you do umbilical artery and middle cerebral artery Dopplers, both are very, very close to normal. Each one does not seem to be abnormal, but when you put the ratio becomes abnormal. So the ratio is more valuable than individual parameters. The CPR improves the sensitivity of umbilical artery and MCA alone. So the use of CPR for surveillance before 37 weeks and trigger delivery at 38 weeks. So this paper showed us the adoption of absolute CPR and UCR thresholds independent of reference charts is feasible and makes clinical assessment simpler than using percentile. So we don't need to go to complicated percentiles for CPR. CPR, is it less than 1 or more than 1? If it is less than 1, if it is abnormal, more than 1, it is normal. That's all. That's a simple way of doing that. Right. Now comes to uterine artery Doppler in the third trimester. Do we still need it? And what the literature says is, when you look at third trimester uterine artery Doppler, then you can see when there's abnormal first and third trimester uterine artery Doppler, you can see the IUGR rate is very, very high. So that means this right? But not only that, if there's an uterine artery Doppler abnormality in the third trimester, they've shown more frequent progression to brain Doppler abnormalities, that's MCA Doppler abnormalities, and brain redistribution appeared 2 weeks earlier and up to 63% of the cases. So if your uterine artery Doppler is abnormal, your cerebral Doppler is likely to be abnormal, more likely to be abnormal, and earlier likely to be abnormal, and higher association with perinatal outcomes. Now we are going to incorporate the Doppler. Uterine artery Doppler as part of third trimester scan, umbilical artery Doppler and CPR when there is an abnormal growth pattern, estimated fetal weight less than 10 centile, and estimated fetal weight between 10th and 50th centile for triaging. Now, very, very important. I'm going to be coming very close to the end of my talk. Listen to the mother, integrate the Doppler and fetal movements, right? When the mother says she has lack of fetal movements, 55% of them experience lack of fetal movements prior to stillbirth. That means more than half of them. So it is better to listen to the mother. And majority 3 to 4 days prior. Of course, there's no fixed number. Now, pregnancies with multiple episodes of reduced fetal movement, low MCA, PI, and CPR have been noted. All 7 perinatal deaths occurred in the appropriate for gestational age group, not the IUGR group. And that's why it's important. AGA fetuses with reduced fetal movement demonstrated significantly lower MCAP and CPR compared to those without RF1. That means the message is very clear. Mother says, doctor, I'm not feeling fetal movements. You do the Doppler. And if the Doppler is abnormal, then that is a combination which you need to be very, very careful about, right? So the CPR is also a better predictor of adverse predictor outcome, which we have seen already. Now, Likert volume. Can we depend on Likert volume? A meta-analysis of 18 trials of AFI less than 5 has shown no association with acidosis or perinatal death in SGA. So we don't need to lose sleep over AFI. Okay. Many times when they do AFI, the delivery takes place. There's no correlation between what the ultrasound said and what happened. Oligohydramnios, lots of Likert comes out. Right? This has happened. So this is something you don't need to worry about because I'm not worried about Likert. Is the Doppler okay? Then I'm ready to take decision on that. So Likert is an indicator of chronic hypoxia. In late onset IUGR, it is acute hypoxia. In acute hypoxia, the Likert will not come down. So there's no point in relying on that. It can remain stable for weeks. So now in the monitoring, do you use the modified biophysical profile? Okay. Now modified biophysical profile, CTG and NST needs to be done, and single deepest vertical pool less than 2 centimeters. And the stillbirth rate 1 week after a normal modified biophysical profile is 0.8 per thousand. The negative predictive value is high. So it is somewhat reassuring that which is there. Right. Now, key message. How frequently do we do monitor and surveillance? Weekly Doppler, bi-weekly CTG, falling CPR means increase your surveillance, and listen to the mother fetal movement count. Right. Now, we want to integrate the CPR and the biophysical profile for delivery timing. We reduce the mortality rate by more than 50%. Biophysical profile less than 4. Spontaneous repeated unprovoked decelerations. Maternal PE is there, absent or reversed umbilical artery end diastolic flow. 36 to 37.6 weeks. Umbilical artery PI greater than 95th centile or estimated fetal weight less than 3rd centile, you deliver the baby. 38 to 39 weeks, between 38 to 39 weeks, if there's CPR reversal, any other finding of FGR, you deliver at that time. So 24 to 28 weeks, there is 2% increase in survival. Why are we saying once one Doppler is abnormal, why not you just go and deliver? Now, the reason is between 24 to 28 weeks, 2% increase in survival per day. So if you gain 1 week, you are going to get a 14% increase in survival of the baby, isn't it? Because prematurity also can kill the baby. So that's why we want a balance to be done. Less than 26 weeks, 50% morbidity and mortality with other things. Between 28 to 30 weeks, 0.7% increase in survival per day. So that 2% increase has gone to 0.7%. GA less than 30 weeks, 8-fold cerebral palsy, 3-fold developmental abnormality. So even though the death has come down, but the morbidity is still there. So we still don't want to deliver the baby at that point. Now, after 30 weeks, survival is 90%. Major complications less than 10% after 34 weeks. Between 34 and 38 weeks, higher NICU admissions, lower risk of long-term complications, and greater than 38 weeks. SGA, if undelivered, stillbirth risk doubles every week. So if you go beyond 38 weeks, it's a small baby, you say, okay, let me wait. Now that baby is more likely to die. So now delivery plan, right? Final. Now we all heard of Barcelona staging. I'm not going to go into the details of staging, but we have simplified it by saying stage 1, umbilical artery high resistance, CPR less than 5th centile. You follow the patient weekly. That's what it says. Umbilical artery absent end diastolic flow, you do follow the patient 3 times a week. Stage 3, umbilical artery reverse end diastolic flow, DV is high resistance, then you monitor, see the patient every day. And when the DV A wave reversal, you decide to deliver. Right? That's what it is. Right. Now, when the weight of the baby is between 3rd and 9th centile, so we are going to slightly look at it in a we have already got the gestational age where to do. When the weight of the baby is between the 3rd and 9th centile, weekly Doppler, growth 2 weekly, biophysical profile and NST weekly. Weight of the baby less than 3rd centile, normal Doppler and Leica. So weekly Doppler, 2 weekly growth and weekly biophysical profile. Now delivery, when the weight is between the 3rd and the 9th centile, is between 37 and 39 weeks. When the weight is below the 3rd centile, you deliver by 37 weeks, right? And then umbilical artery, PI greater than 95th centile, CPR less than 1st centile, oligohydramnios, interval growth is poor, then you do weekly Doppler and NST. If it is normal, then you redo it weekly, and then gestation age is less than 37 weeks. Deliver by 37. So our goal is to achieve 37 weeks in this case. Now, if there's an umbilical artery showing absent end diastolic flow and between less than 32 to 34 weeks, you do Doppler 3 times a week and biophysical profile. And if everything is normal, you again keep circulating till you reach 32 to 34 weeks. And then you can deliver, because with umbilical artery absent end diastolic flow, our delivery is going to come down to 34 weeks. Now let's say umbilical artery reverse end diastolic flow. Then what happens is you deliver by 30 weeks. You do daily monitoring and deliver by 30. We are just going to gain time in order to reduce fetal perinatal morbidity. Now, what about critical abnormal Dopplers? Umbilical artery reverse end diastolic flow, deliver by 30 weeks. DV A wave reversal, deliver by 26 weeks. Because by that time, if the DV A wave reversal is there, but at this point of time, we tell the parents, this is not something which we are happy about. But if you don't deliver, the baby is going to die. So they take a chance whether they want to deliver the baby or they want to go for natural process. So summary. Symphysis to fundal height, screening tool for FGR in low-risk women with normal uterine artery Doppler flow. Uterine artery Doppler, all high-risk women and all nulliparous low-risk women. Serial growth scans from 26 weeks onwards. Risk factors for FGR, abnormal uterine artery Doppler, abnormal fetal growth velocity. Abnormal growth scan at 36 weeks, all women. Risk of recurrence based on severity and onset. Overall chance of recurrence in subsequent pregnancy is less than 25%. Risk is higher if severity of FGR was more and associated with hypertensive complication. Obviously, if there's maternal disease, it's going to recur. Then thrombophilia testing. Now, there are 2 trials called the TIPS and the FRUIT trials. They found no benefit of low molecular weight heparin in women with thrombophilia and a history of placenta-mediated pregnancy complications. there is no indication for routine screening for inherited thrombophilia in women with prior FGR. Again, a very profound statement, but in practice, we can see a lot of different things that happen. Now, what about the preventive role of aspirin and low molecular weight heparin? History of placenta-mediated FGR and those at risk for preeclampsia. Aspirin at the dose of 150 mg taken in the evening, starting at 12 to 16 weeks. Low molecular weight heparin is not recommended. Right? History of APLA and placenta-mediated FGR. Low molecular weight heparin may be considered in selected cases. Those who have experienced recurrent complication despite aspirin treatment or called as aspirin failure. So counseling and postpartum follow-up. Twice the risk in 1 year. Greater than 1/3 develop hypertension at 2.5 years. Twofold risk in congenital heart, cardiovascular disease, and fourfold risk in type 2 diabetes mellitus. So these are all babies are going to have all these problems, so we need to follow them. So the mother also needs to be followed up if she's had preeclampsia, and we need to follow up a cancer screening. And finally, I'm going to test to know whether the Doppler is understood. So this is a case study. All of you can test this. So what do you think of this? She's 31 weeks. Okay. So obviously there is umbilical artery showing reverse diastolic flow at 31 weeks. You can see, and there is another, this is a twin pregnancy. You can see one baby showing normal umbilical artery flow, the other showing reverse umbilical artery flow. So the first question you ask here is what type of twins it is. If it's a monochorionic twin or a dichorionic twin. If it's a monochorionic twin, then we call this a selective growth restriction, and the route is different. This reverse diastolic flow doesn't mean this baby is going to die. It has got it's got stage 3 or type 3 SFGR. If it's a dichorionic twin, then that baby has got a high risk of perinatal mortality and morbidity. So that's it. Then here's the primary at 22 weeks. So what is your interpretation of this? Primary at 22 weeks.
Early onset.
Yeah, earlier. Baby is small. And then you can see the ductus venosus here. Okay. Showing a very irregular, it's a very bad ductus venosus. And this baby is going to have imminent fetal death. So here's another primary at 22 weeks. At 22 weeks, you can see reversal of diastolic flow in the umbilical artery. And this is the kind of babies where we would like to investigate. Because too early onset, like 22 weeks, already Dopplers are severely abnormal and baby is very small. So these are the ones which goes in with. So I will close with this just to say that every Wednesday morning, we have a clinical meeting, which is called the Mediscan clinical meeting. It's called Sono Academy. You just go to Google and type Sono Academy, and anyone is free to join every Wednesday morning, 9 a.m. to 10 a.m. And all the previous meetings also recorded. You can also present your cases. So thank you very much for a patient listening. And thank you for the opportunity.
Hello.
Hello, Dr. Suresh. Hello.
Yes, ma'am.
Vijay, I was just thinking, when there's such a, Dr. Suresh must be tired from A to Z. You
I
have
know,
taken
ma'am.
such detailed, every small point explanation of the FGR. Very nice. I think for the PGs, it is definitely worth not listening only, but I think re-listening 1, 2, 3 times more. even he could get many few small points. So
I
very
have-
nice. It's just
I have to acknowledge that a lot of this homework was done by Dr. Sudarshan.
oh, okay.
Because
Sudarshan is his son, ma'am. His son.
recently, the FIGO has come out with an excellent paper on combining all the articles which have been done before. They have come to a consensus, and I encourage everyone to read that FIGO on, because that one paper is enough reference for all IUGR answers that you need.
So you can post that paper, the heading
Yeah,
into the
I'll-
group,
I'll do that.
or
Yes.
you can.
Yes,
I
sir.
Dr. Vijay, have we made a group or something? No.
No, we haven't made, madam. Only maybe we can make a group with all
Yeah,
the
next time
teachers.
onwards we can in the
Teachers
different
so that we can share
So
our
it
PDFs.
is in the international. I'll just write the paper thing there. It's called. I'll put it in the chat box.
Yes, sir.
Yes, sir.
Okay, that will be great because it will be of help to everybody. Should go on.
I'll just see
Sir,
it.
that was a wonderful talk, sir, starting from the basics, because
Thank
they should know how the placental blood supply and what are the maternal risk factors and what are the Doppler changes, everything, no, because whether to do uterine artery in the third trimester, that was the biggest doubt the PGs had, and when to terminate it, that is more important. How to terminate, that obstetrician might decide, but when to terminate, only one doubt, sir. If there is abnormal Doppler, should we do a section or we can allow a normal labor?
Yeah, that's a good, very, very good question. I had that slide, and first I didn't that. So the recommendation is that if the gestational labor induction is recommended when there is forward flow in the umbilical artery. The induction of labor can be, and that too after when you're able to reach 37 weeks. Earlier deliveries are all by cesarean section.
Yes, sir. Okay, sir.
And
So,
actually, when I try to put this PDF, it says it's not allowed. It's not giving me. It's not giving you the permission to do that.
access, sir.
I will pass it on to Dr. Vijaya and can pick
Yes,
it.
yes, sir. Yes, sir. Yes, sir.
Yes, sir.
Yeah,
Thank you.
Vijay, you can send it to me
Sure,
also.
ma'am. Sure, ma'am. I'll pass it on to everyone. And
Yes.
I'm very, very happy, sir. We had almost 250 students logging in for my first Aksharam. So I'm so happy. And sir, thank you so much, sir. It's because of you. Because I put Dr. Suresh name, everybody said they logged in. I don't think it will come to any other speaker. And ma'am, Karpagam, would you like to say?
Yeah.
There's one very important question which is there. I think you should answer that.
Chat box, sir?
If there's
Yeah, chat box.
one-sided
Yeah.
urinary Doppler force with increased PI, should be considered high risk or how to for the very important question, because many times this happens. Only the mean PI is considered. You have to take both sides, and only the single side we don't, because on the side where the placenta is, the PI will be lower. On the opposite side, the PI will be higher. So if the placenta is completely on the right side, you will always get a high resistance on the left side. So don't worry about it.
Okay, sir.
Okay. Thank you very much, sir. From what I should say in my language, it was a marathon session with lot of inputs from basics to everything crystal clear. And I'm sure, PGs will not have any doubts in FGR, and they'll be able to manage FGR in terms of, not only in terms of monitoring, in terms of decision making, delivery intervals, weekly, how frequent they have to monitor, and Barcelona criteria, everything has been crystal clear. Thank you so much. For those who are not able to log in, please we'll get the recorded version of this webinar, and we'll pass it on to, please pass it on to your colleagues who are not able to log in, and let them make use of this session. It was an amazing session. So thank you so much for joining. And I really understand.
Just wanted to mention, we have about 30 people here also listening.
Very good. Your side, sir.
Our students are all here.
Oh, thank you so much, sir. Thank you.
Once again, I'll just show.
Yes, sir.
Thank you so much, sir. Okay, very good.
Oh, super, sir.
So all your fellows and
Yeah.
also listening.
Yes.
Thank you very much, sir.
Thanks
Thank you
to
very much
Oxy
for
for that.
including.
Yes, sir.
Thank you.
Without Dr. Suresh, there is no ultrasound, there is no Doppler, as far as we know, sir. So we will always keep you with us ever, sir, in our Oxy armamentarium, always in all our teaching schedule. Thank you so much, sir.
you.
Immediately accepting and obliging, sir.
Thank
Thank
you.
you. And your son Sudarshan is also in a very, very pleasant way, and he is also coming up. Super, sir.
Thank you.
Thank you so much. I thank Karpagam. Can you give
Yeah,
a
Dr. I will just share the screen for the next things because Dr. Mala is not able to join. So I will be delivering the vote of thanks. First of all, thank you so much, Vijaya madam. Thank you so much, Geeta Lakshmi madam, the entire Oxy team for this entire webinar concept, Aksharam. And I also thank Foxy President, Dr. Jaideep Tang, our Secretary General, Dr. Madhuri Patil, and Dr. Kiran Pandey. When I just texted her, madam immediately agreed and she was so keen. And she said, we'll combine hands with together and we'll do this session as a part of Medical Education Committee. Thank you so much, Kiran madam, for this excellent opportunity. And we look forward to having further sessions henceforth. So it will be a monthly webinar. And we'll intimate to all the, please inform your friends and colleagues also and other faculty also, even practicing consultants also to log in and just make use of these Aksharam classes. And I thank Shield Company for the platform. And above all, to the teachers of teachers, I call the father of fetal medicine, Dr. Suresh sir, for an excellent session. No, I mean, no stone has been left unturned in FGR. I would say that because everything has been spoken about and it's an amazing session. Thank you so much to you, sir, and also to Sudarshan for helping you prepare the slides. Thank you so much once again. And all the delegates who have logged in, I know it's getting late around 8 to 10. Still, all of you have logged in.
We have
to the
finished
entire
on
session.
time, actually, even though we started. We
started a bit late, but still everybody stayed back throughout. And thank you so much for the active participation. We look forward to your participation in all the sessions and make use of this class series, Aksharam class webinar series. Thank you so much.
One
everybody.
small doubt is there, sir, in the chat box. Thin placenta, you mean it is by thickness, size, or mass? Sir, you unmute yourself.
Thin placenta means, see, the placental thickness is equivalent to, in millimeters, is equal to gestational age. Okay. If 25 weeks, we expect a placenta of 2.5 centimeters, 25 millimeters. Okay. So thin placenta means, so usually we don't go and measure, but a remarkably thin placenta will be very obvious.
Obvious.
You keep seeing placenta at 20 weeks, 25 weeks, very easy to identify that the placenta looks thin.
Yes, sir.
Yeah.
Yeah, I think we can close the session, Karpagam.
Thank
Thank
you.
you,
Thank you very
everyone.
much,
Thank
everyone.
you so much, sir.
Have a great weekend.
Bye.
All of you have exercise your franchise and vote tomorrow.
Yes, yes, most important.
Please don't ignore to vote, and it's our right and duty to vote. So
Yes.
exercise your franchise and vote tomorrow. And happy weekend to all of you.
Thank you.
Thank you,
Bye.
sir.
Thank
Good
you so
night,
much
sir.
and good night.
Kiran ma'am, I think logged out, I think.
Madam is there. Thank you so much, Kiran ma'am.
Kiran ma'am,
I think she is
muted us.
video and audio window off.
Okay, okay.